Good morning all. I am Dr. SOUMYA A R, practicing periodontist and implantologist. I have completed my post-graduation from the Department of Clinical Periodontology and Oral Implantology, Royal Dental College, Palakkad. Today we will be continuing with Section 5 of Misch Contemporary Implant Dentistry as a part of GCOI International Implant Summit 2026 Reading Club. We are moving on to chapter number 23. The chapter number 23 under part 5 is treatment planning for the edentulous posterior maxilla. Under this, we will be reading about inherent disadvantages of posterior maxilla treatment and the various treatment options for posterior maxilla. So starting with inherent disadvantages of posterior maxilla treatment. It is poor bone density, decreased available bone, increased pneumatization of the maxillary sinus, resultant increased crown height space, lingual oriented ridge position, anatomic location, increased biting force, requirement of greater surface area diameter implants and minimized occlusal forces. Maxillary sinus has high incidence of pathology. So all these are the inherent disadvantages of posterior maxillar treatment. Now moving on to sinus graft options for the posterior maxilla. A classification based on the amount of available bone height between the floor of the antrum and crust of the residual ridge in the region of ideal implant location was presented by Misch in 1987 and later modified by Resnick in 2017. So we have a Misch-Resnick maxillary posterior classification. There exist 4 treatment classifications based on the amount of bone available below the maxillary sinus, that is SA1, SA2, SA3 and SA4. Because implants in the posterior maxilla are susceptible to biomechanical stress, each category has been further divided into 2 divisions, favorable and unfavorable force factors. So coming to subantral option 1, that is conventional implant placement. It is applied when there exists sufficient available bone height to permit the placement of endosteal implants without entry into the sinus proper. So we are reading figure number 23.12. So in subantral option 1, protocol decision tree related to favorable versus unfavorable factors. So in the subantral option 1, the implant placement is, it doesn't penetrate sinus. So there are 2 types, that is SA1A and SA1B. In SA1A, the unfavorable conditions when there is deformed bone, high force factors, increased crown implant ratio, implant height, host bone more than or equal to 10 mm, implant length more than or equal to 10 mm. And in SA1B, favorable conditions when D2, D3 bone are available, minimal occlusal force factors, favorable crown implant ratio. Implant height, host bone more than or equal to 8 mm, implant length more than or equal to 8 mm. Coming to subantral option 2, that is sinus lift and simultaneous implant placement. It is selected when there is a minimum of 6 or 8 mm of vertical bone present. So we will be reading figure number 23.14. Subantral option 2, SA2, protocol decision tree related to favorable versus unfavorable factors. So SA2, it is implant placement plus elevation 1 to 2 millimeters. Again SA2A and SA2B. Under SA2A we have unfavorable conditions, that is deformed bone, high force factors, increased crown implant ratio, implant height, host bone more than or equal to 8 mm, implant length, bone height plus 1 to 2 mm. And under SA2B, the favorable conditions when there is D2, D3 bone, minimal occlusal force factors, favorable crown implant ratio. Implant height, host bone more than or equal to 6 mm, implant length, bone height plus 1 to 2 mm. Coming to box number 23.2, Essay 2 implant placement. Membrane bump 1 to 2 mm, no graft. Osteotome technique. Indications: favorable conditions more than 6 mm host bone, implant length equal to bone height plus 1 to 2. And unfavorable conditions more than 8 mm host bone, implant length equal to bone height plus 1 to 2. Subantral option 3. Sinus graft with immediate endosteal implant placement. It is indicated when at least 5 mm of vertical bone height and sufficient width are present between the antral floor and the crust of the residual ridge in the area of the required prosthodontic abutment. So here we will be reading figure number 23.15. Subantral option 3 technique. Implant placement with bone graft, crustal and lateral wall. Decision tree related to favorable versus unfavorable factors and crustal versus lateral wall technique. So in essay 3, it is sinus augmentation plus implant placement. Again, essay 3 is divided into essay 3A and essay 3B. Essay 3A, unfavorable conditions, D4 bone, high force factors, increased crown implant ratio. Implant height, host bone more than or equal to 8 mm, implant length, bone height plus 3 to 4 mm crustal, bone height plus more than or equal to 4 mm lateral. In essay 3B, favorable conditions, D2 or D3 bone, minimal occlusal force factors, favorable crown implant ratio, implant height, host bone more than or equal to 5 mm, implant length, bone height plus 3 to 4 mm crustal, bone height plus more than or equal to 4 mm lateral. Now moving on to box number 23.3. Essay 3, subantral option 3 requirements, graft plus implant placement, sinus grafted with implant placement, lateral wall or osteotome. Indications: favorable conditions, more than 5 mm host bone, implant length equal to bone height plus 3 to 4 mm crustal and more than 4 to 15 mm lateral. And unfavorable conditions, more than 8 mm host bone, implant length equal to bone height plus 3 to 4 mm crustal and more than 4 to 15 mm lateral. Next is subantral option 4, sinus graft healing and extended delay of implant insertion. The maxillary sinus region for future endosteal implant insertion is first augmented. This option is indicated when less than 5 mm remains between the residual crust of bone and the floor of the maxillary sinus. We will be reading figure 23.17. Subantral option 4, bone grafting indications. So essay 4 is sinus augmentation, favorable or unfavorable condition, less than 5 mm of host bone, unfavorable essay 3 conditions, that is ridge augmentation needed, existing sinus pathology. And here we will be opting for delayed implant placement. So that's all about chapter number 23. Now we are moving on to chapter number 24. Chapter number 24 under part 5 is the Edentulous mandible, fixed versus removable prosthesis treatment planning. Under this, we will be discussing about implant overdentures advantages, RP4 and RP5. RP4 means removable prosthesis which is totally implant supported. RP5 means removable prosthesis which is primarily supported by the soft tissue. So coming to implant overdentures advantages, RP4 and RP5. For an implant supported overdenture, the implants ideally should be placed in plant specific sites and their number should be predetermined by the clinician and patient. The primary indications for a mandibular implant overdenture, that is IOD, are problems often found with lower dentures such as lack of retention or stability, decrease in function, difficulties in speech, tissue sensitivity, and soft tissue abrasions. If an edentulous patient is willing to remain with a removable prosthesis, an overdenture is often the treatment of choice. In addition, if cost is a concern for the patient, the overdenture may serve as a transitional prosthesis until additional implants may be inserted and restored. When evaluating mandibular IODs, many advantages exist. So, we will be reading box number 24.1. Advantages of mandibular implant overdentures. One is enhanced soft tissue support. Second is increased chewing efficiency compared with conventional dentures. Third, less expense or implants. Fourth, aesthetics. 5, ease of hygiene. 6, parafunctional habits. 7, less food impaction. Now moving on to fixed prosthesis. In mandibular fixed implant prosthesis, there are several advantages like psychological, improved speech, decreased soft tissue irritation, increased biting force, less bone resorption, less soft tissue extension, less long-term expenses, less interocclusal space requirement, patients with limited dexterity, increased chewing efficiency. So, these are the different advantages of mandibular fixed implant prosthesis. Now, we are moving on to summary of chapter number 24. The treatment of the edentulous mandible is a common procedure that implant clinicians see on a regular basis. There exists a full array of options for patients which include 5 fixed treatment plans and 4 removable overdenture treatment options. IODs borrow several principles from tooth-supported overdentures. The advantages of IODs relate to the ability to place rigid, healthy abutments in the positions of choice. The number, location, superstructure design and prosthetic range of motion can be predetermined and based on a patient's expressed needs and desires. 2 implants placed just anterior to the mental foramina rarely should be used. The overdenture should be designed to satisfy the patient's desires and anatomic limitations predictably. Many completely edentulous patients desire a fixed restoration rather than a removable prosthesis. The financial cost for a fixed implant prosthesis often have been a deterrent but should be more similar to a completely implant supported overdenture. The number and position of implants should be related to the amount of stress transmitted to the bone during occlusion and parafunction and the density of the bone. Other considerations include mandibular flexure and torsion. 5 treatment options generally are available for this fixed complete mandibular implant supported restoration. These treatment options accommodate the stronger mandibular bone dynamics without affecting the prosthesis. So that's all about chapter number 24. Now we are moving on to chapter number 25. Chapter number 25 under part 5 is the edentulous maxilla, fixed versus removable treatment planning. Under this we will be reading treatment planning factors, fixed maxillary treatment plans. So under treatment planning factors, the important factors are smile line, lip support, ridge position, soft tissue, crown height space, that is interocclusal space. Now moving on to fixed maxillary treatment plans. Reading box number 25.1, maxillary fixed prosthesis treatment plan 1. Indications: square arch form, implants 6, positions bilaterally canine, second bicuspid, first molar. Now moving on to figure 25.8, that is fixed treatment plan 2. In an ovoid dentate arch form, 3 implants should be planned in the premaxilla, 1 in each canine position and 1 additional implant. In addition, at least 4 posterior implants should be splinted to form an arch. Now reading box number 25.2, Maxillary fixed prosthesis treatment plan 2. Indications: ovoid arch form, implants 7, positions bilaterally, central incisor unilateral, canine, second bicuspid, first molar. Now moving on to figure 25.9, fixed treatment plan 3. In a tapered arch form, the anterior cantilever is greater and should be supported by implants in the premaxilla. At least 4 posterior implants should be added to restore the completely edentulous arch. Now reading box number 25.3, maxillary fixed prosthesis treatment plan 3. Indications: tapered arch form, implants 8, positions bilaterally, central incisor, canine, second bicuspid, first molar. Moving on to figure number 25.11, the ideal 7 implant positioning for a maxillary edentulous arch includes at least 1 central incisor position, bilateral canine positions, bilateral second premolar sides, and bilateral sides in the distal half of the first molars. In case of heavy stress factors, an additional anterior implant and bilateral second molar positions, that is to increase the anterior posterior distance, may be of benefit. Now we will be reading box number 25.4, maxillary fixed prosthesis treatment plan 4. Indications: shorter treatment time required, contraindication to bone grafting, low force factors, then implants 4, positions will be bilaterally, anterior and posterior angled at 30 to 45 degrees anterior to sinus. With this, we are concluding our session of part 5. It's an absolute pleasure to be a part of GCOI IIS 2026 Study Club. Thank you for your patient hearing.